Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
Pretty straightforward case that has a little bit of a twist towards the end. This is a 60-year-old female, never smoker, with a history of asthma and obstructive sleep apnea. She presented to her PCP for upper respiratory infection-like symptoms. She had a runny nose, a sore throat, but also had a minimal cough that would not go away with antitussive therapy. Her performance status was an ECOG of 1. So as mentioned, her past medical history is consistent with asthma and obstructive sleep apnea. She was on an occasional inhaler. She is a never smoker. She is married with 2 kids, and she really had no family history of any relevant malignancy, so it was non-contributory. So the primary care physician, after trying to treat this cough for several weeks and it not going away, did eventually order, at the request of the patient, a CT scan, which surprisingly revealed the following. And I'll turn it over to Dr. Ginsberg to review this imaging before we move forward any further.
So on the CT scan, we see a 5.5 centimeter right middle lobe mass, which is FDG avid with an SUV of 7.1 on the corresponding PET CT. And this is suspicious for a primary lung tumor. The MRI of the brain was negative for any metastases.
Her primary care physician was highly concerned of a malignancy, with the understanding that 20% of all lung cancer now occurs in never smokers. So the patient was referred to interventional radiology, pretty straightforward. There was a CT guided biopsy performed, consistent with a napsin positive, TTF1 positive adenocarcinoma. Now, interestingly, while they did 2 cores, the tissue was insufficient for next generation sequencing, which unfortunately is not an uncommon scenario, even in the academic halls of Hopkins. She was subsequently referred to an interventional pulmonologist, which did an EBUS to sample both hilar and mediastinal lymph nodes. 4R, level 7, and 10R were all negative. And based on the fact that her mediastinum was negative, she underwent a right middle lobectomy. Interestingly, the final stage of this right middle lobectomy was a T2N2 adenocarcinoma. So while her EBUS was negative, and while even at the time of the surgical resection at the pathology assessment, there were no N1 nodes involved, there was an incidental N2 node found. So this gave her a stage 3A T2N2M0 adenocarcinoma, or excuse me, a P-T2N2M0 adenocarcinoma. As we do with all of our, even our early stage lung cancers, it is reflexively sent off for both PD-L1 and NGS. And the PD-L1 returned with a score of 20%. And not surprisingly, being a never smoker, the patient's tumor did harbor an EGFR exon 19 mutation.
So, Dr. Levy, before we go on, we have some non-oncologists in the audience. Would you explain a little bit about EBUS, what it stands for, and when you expect your patients to go through it? And then I'll ask Dr. Lanuti to explain about the right middle lobectomy and how that's done and what are the options there. And then we'll come back to this question of whether we always should send NGS, which I believe is next generation sequencing, and what PD-L1 testing might mean. So can you elaborate a little bit about EBUS for those who are not in the medical field?
Yeah, so EBUS stands for endobronchial ultrasound. It's a way to assess nodal involvement of a lung cancer. It is usually performed oftentimes by our interventional pulmonologists, but can also be done, depending on the institution, by the thoracic surgeons. And they're able to go down and assess nodal involvement of both hilar nodes. Those are nodes that are regional, close to the cancer, but more importantly, mediastinal lymph nodes. Those are seen here as 4R and level 7. And that's important for many institutions and for guidelines. The presence of mediastinal involvement really elicits a fork in the road on how to best treat patients moving forward. At our institution, patients that do have mediastinal nodal involvement will oftentimes get some sort of induction treatment first prior to surgery, whether it be chemotherapy or chemotherapy with radiation. So it's important. Interestingly, PET scan does a pretty good job of lighting up the mediastinum, and I'm sure Dr. Ginsberg can relay more information than I can on this, but there is a false negative rate with PET scans of around 5 to 10%. So even if the PET scan does not light up lymph nodes in the mediastinum, they still can be positive. And that's why all of our patients who are surgically resectable outside of a peripheral T1 at our institution would warrant an EBUS assessment to assess the mediastinum again, which would subsequently inform how to best proceed for a patient moving forward.
Excellent. Dr. Lanuti, what can you tell us about this choice of right middle lobectomy?
So the approach to a middle lobectomy is, for surgeons, would be that the patient would be or have to be assessed for medical fitness. This had a performance status of 0 to 1, so that is encouraging. We would also then look at the patient's pulmonary function and get formal pulmonary function testing, which I don't see here, but I imagine it was preserved. And if they have no significant cardiac disease, then we feel that they are a safe candidate for surgery. The approach for middle lobectomy can be done with, in these days, preferentially with a minimally invasive technique, and be it either a VATS or a robotic technique. If the surgeon felt that the tumor was too large, or there were perhaps lymph nodes that were large in the hilum, they could go to an open technique. The goal of the video or the minimally invasive technique is to remove the middle lobe with a negative margin, remove the regional lymph nodes, and then, even though this case had an EBUS that was assessing the nodes, we also sample, or some surgeons do, lymphadenectomy of the N2 nodes, which in this case would be 2R, 4R, level 7, and then there's paraesophageal and inferior pulmonary ligament lymph nodes that we take out as well, which are called level 8 and level 9.
So great. I presume, for the benefit of those who are not oncologists, that we have cancer spreading two different ways, via bloodstream, or just, which I call taking the highway and you don't know which exit it's going to take, or the local streets where they can be stopped at various checkpoints. And these checkpoints or filters are little lymph nodes in the center of the chest, a space called mediastinum. So in this case, that mediastinal space, where when lymph nodes are present on the same side, we call them N2, they were positive in the final pathology stage. Is it the same thing for us to discover this on final pathology than if they were visible on a PET scan, or is it a little bit different for prognosis of the patient that we found it as a surprise?
Preoperatively, if we identified lymph nodes that are in the N2 position or the mediastinum, yeah, the prognosis is clearly different. It's a stage 3 tumor. And in that scenario, as was mentioned, we often consider a different treatment strategy, where there's an induction strategy with chemotherapy. In some institutions, it's chemotherapy plus radiation, followed by a surgery, which would be, in this case, a middle lobectomy or an anatomic resection. but clearly 3A disease preoperatively identified has a different prognosis compared to incidental N2 disease in a single station.
So incidental being better than previously obvious.
Incidental in a single node, yes.
Great. Dr. Levy, is it standard of care to order next generation sequencing and PD-L1 on early stage lung cancer patients? Or do you think that in the community, it's okay to not order these tests?
How much time do I have to answer this question? It's quite controversial and contentious. And, full disclosure, I'm not fluent in cost-effective analyses. I can tell you in the academic centers, we have a lot of trials prior to ADAURA, which I'm sure we'll mention, which guide therapies based on next generation sequencing, specifically EGFR and ALK. We of course have the Alchemist trial, which is a cooperative group study trying to enroll patients on studies, 2 studies, actually 3. But 2 of these studies are selecting therapies based on EGFR, if patients have EGFR mutations or not, or ALK mutations, and then patients are receiving targeted therapy adjuvantly. So I will tell you that for trial purposes, yes, it makes a lot of sense. The question is, does it make a lot of sense in routine clinical practice? And, there's pros and cons to this. Some people say, look, I don't need it now. We don't have any good data to guide our therapy. So why order it? I think the argument to that is that, well, some of these stage 3 patients are going to met out at some point, unfortunately, and having that information a priori may make a difference in how quickly you can act on if they progress, or if their tumors progress, or if they have metastases. So we've made it a rule that reflexive testing should be done for all patients, mostly for clinical trial purposes, but also for those scenarios that unfortunate progression does occur. And we have that information at our fingertips to make decisions.
Good. And for PD-L1, you have the same opinion, or is there more nuance to that?
I think it's a little bit different nuance. I think, unfortunately, it's a one-stop shop for us. We send it off for PD-L1 and the NGS lab kind of concurrently. Yeah, I think PD-L1 is a little bit more nuanced discussion, given that we really don't have any good data currently, at least in the adjuvant setting, although there's a ton of neoadjuvant immunotherapy trials that have made a splash in some high impact journals for lung cancer. So I think that PD-L1 is a little more nuanced. I can say standard of care, I'll put my nickel down and say you don't necessarily need next generation sequencing for early stage lung cancer. We do it as part of a reflexive pattern, and we do it because we are putting people on clinical trials adjuvantly.
Great. So the other nuance, if I may, is there anything special about EGFR positive patients and their candidacy for immunotherapy, which would be different than those who are EGFR not mutated or wild type?
Good to have another medical oncologist. Yes, clearly patients that are EGFR positive, as you mentioned, do not respond well to immunotherapy. And there's also a sequencing challenge with toxicities by receiving immunotherapy followed by targeted therapy for these patients as well.
Okay, great. So are you ready to move on with the case and what you
ready to move on.
Okay, so let's see.
So I think, the bottom line is that we're certainly in a very rapidly evolving field in the adjuvant space. So this patient did get 4 cycles of adjuvant chemotherapy with cisplatin and pemetrexed. And I'd make the argument that, platinum doublet remains the standard. And I would say that cisplatin remains the standard. And every effort should be made to give cisplatin for these patients with resectable lung cancer. I think that the questions that really remain are one, the role of postoperative radiation therapy, otherwise known as PORT, for incidental N2, and what the bang for the buck there is. And then more importantly in our field and in the medical oncology world, what's the role for osimertinib in light of some of the data that's recently been presented? So I'll stop there.
Before we get to that, let me ask Dr. Robinson to talk about radiation therapy and how it has evolved in this space in stage 3 lung cancer and the curative management in particular. We can talk about nuances of it, but just the specific questions surrounding this case as to why radiation is sequential and not concurrent, and how much is enough. How much is not enough? What would you say, Dr. Robinson?
Yeah, thanks for the opportunity. This again is quite nuanced. So I think, not stealing any thunder from Dr. Levy, but it's probably important to recognize that the question of the platinum-based doublet chemotherapy is been answered by multiple randomized trials. And while the additional benefit in survival is modest, it is reproducible, and it's something that again has been tested rigorously. For postoperative radiation, and again for the non-oncologists here, the idea here is that the cancer in the lung has been resected, but we've identified through sampling additional lymph nodes that harbor cancer. And so the concern is that there will be additional lymph nodes that were not sampled that also harbor additional deposits of cancer. And in the absence of seeing anything on the CT or PET scan, the question is whether there's a benefit to then irradiating those regions prophylactically to sterilize any remaining cancer that's left behind. Prior to effective platinum-based chemotherapy, this was actually tested decades ago in the 60s and 70s through a series of randomized trials. And what we actually found was that in those patients, there was actually worse outcomes, meaning that their survival was worse when we gave adjuvant radiation. Now, the caveats to that is that those are very old studies. We treated an enormous field. So they treated essentially the entire middle of the chest and then the ipsilateral, the lung that was adjoining to the cancer. And also use outdated delivery methods. So very, machines called cobalt machines, which would deliver, less precise dose and dose that's closer to the surface of the skin. As it turns out, there's a number of toxicities that can occur to that, primarily because of the heart and lungs being irradiated to high doses. So, I would say that if you just use that data alone, then I think the answer would be clear that there's no role for post-op radiation. The difference is, just like medical oncology has been making leaps and bounds over the years, radiation techniques have evolved tremendously. And so we now have the ability to give much more precision targeted radiation. We also constrain the area we treat just to the regions where the lymph nodes are at the highest risk. And we have the ability to give heart and lung doses that are probably a tenth of what we gave before. This hasn't been tested yet in a randomized trial. There's a recent trial right now, which is just finished up, called the Lung Art trial that was run in France, where all patients got platinum-based chemotherapy and then were randomly assigned to radiation or not. And so we anxiously await those results. In the absence of those results, I'd say the best data is non-randomized data, where we've looked at large databases. We published a paper several years ago in the Journal of Clinical Oncology, looking at patients who all received platinum-based chemotherapy. And those patients who received port radiation using modern radiation techniques seem to have an additional survival advantage on par with what platinum-based chemotherapy gives. So at our institution, we routinely offer this as an option. However, we do it with a tremendous caveat for older patients, those with a lot of comorbidities, those who maybe just barely made it through the surgery and the chemotherapy. We consider just watching those patients, and everyone else, we tend to offer it.
Great. And what dose do you use? You may have said it, but
no, I didn't. Yeah. So in general, we talk in terms of the gray, and we deliver 1.8 to 2 of those gray per day. Typically, we'll give 45 to 50 gray to that region that we talked about.
So how many weeks is a patient committed to this?
Typically about 5 weeks. That's 5 days a week, Monday through Friday, for 15 to 20 minute visits. But it's kind of a rigorous 5 weeks where you're coming back and forth every day.
So if somebody lives far, it could be a challenge.
Absolutely. It definitely is one of the things we take into account.
So are there any avant-garde techniques that you discuss with those patients? Are there other options other than driving for 5 weeks?
Yeah, outside of a clinical trial, no. We are at several institutions, including our own, are designing trials where we're trying to shorten that course of radiation to 2 or 3 weeks to make it a little bit more palatable. But one has to be careful because you're increasing the dose per day by doing that. And so, in the absence of modern radiation delivery machines or some of these academic facilities, that can be a little bit more at a higher risk.
And my last question or clarification is that obviously this chemotherapy we know can be given safely concurrently with radiation. But in this situation, you do one thing at a time. And if you want to elaborate on that, why that is.
Yeah, thanks. Great question. Yeah, no, wonderful question. We know that in patients who have tumors where they're intact and they haven't been removed surgically, that there's high rates of failure in the tumor or the lymph nodes. And so we give them everything we can. And giving chemotherapy and radiation concurrently improves the chances of sterilizing that cancer than giving it sequentially, meaning one after the other. However, it comes at a cost, and that cost is toxicity. We generally feel that toxicity is worth it if the difference is being able to control the tumor or not. Once the tumor is out and has been removed surgically, that balance of risks doesn't make quite as much sense. There has been some studies done where we've given it concurrently and it seems, quote, tolerable. But I think tolerable is all in the eyes of the beholder. You know, as a physician, we can easily, more readily say that than the patient. I also think that when we start thinking about using drugs like pemetrexed, we also have to be more thoughtful, because many of those studies were cisplatin etoposide-based or other based regimens. Pemetrexed increases the risk of a complication of radiation called pneumonitis, which is an inflammation of the lungs that can occur. And that risk is also higher if you give it concurrently and to older patients.
Excellent. So I'll come back to you, Dr. Levy, finally about this osimertinib business, this pill that patients can take, and you say there's some real data. Do you want to elaborate on that?
Yeah, I think that what we've known thus far prior to the ADAURA data is that osimertinib is a next generation tyrosine kinase inhibitor for EGFR, and at least in the metastatic setting, outperforms first generation TKIs per the study called the FLORA study.
So EGFR is something that's like an accelerator pressed in a tumor that's driving the tumor growth, and you want to stop it?
Correct. I mean, it's EGFR, epidermal growth factor receptor mutation. It's a relevant alteration in lung cancer that, again, leads to constitutive activation and uncontrolled cell growth. And it is a player in lung cancer, and we can act on it, and that's called actionable. So we have these targeted drugs now that we can, once we identify the mutation, we can wed that mutation to a particular targeted therapy. And what we've learned, at least up until this summer, is that in the stage 4 setting, that there are tyrosine kinase inhibitors that are better than others. So osimertinib was directly compared to first generation tyrosine kinase inhibitors and outperformed it in terms of PFS, progression-free survival, and most importantly, OS. Fast forward now, because many patients ask, well, you've got all this great drugs and targeted therapies in the stage 4 setting, but what about an earlier stage? And what we've learned at ASCO this past summer in May of 2020 is that there may be a real role for adjuvant osimertinib for resected EGFR lung cancer patients. And just briefly, this was a very clean study of resected EGFR mutant lung cancer that were randomized 1-to-1 to either osimertinib versus placebo. Remember, at the time of the inception and the crafting of this trial, placebo, doing nothing for targeted therapy, was the standard. Now, patients were allowed at the discretion of the physician to first get chemotherapy, which many of the patients did because chemotherapy is the standard of care. But subsequent to that, they were allowed to go on to either a EGFR-directed tyrosine kinase inhibitor or nothing. And what we saw was quite impressive. We saw a huge benefit in something called a DFS, or disease-free survival, which is essentially how long the patient is on drug without a recurrence and or death. And they looked at something called a hazard ratio, which really calculates how significant the benefit is. And the hazard ratio in this setting, I believe, was 0.16, which means at any one point in time that you're receiving this, you have an 84% less risk of either recurrence or death compared to receiving nothing. Now, the challenges of this trial was that they don't have an overall survival benefit yet. And the question still remains for many of us in the medical oncology world, should it be fair practice to institute a drug adjuvantly when you don't have survival data? So I think that there's many different, the results of this study have elicited a lot of philosophical, existential, medical, scientific questions about how trials are designed and what the proper endpoint is. I can tell you with a DFS benefit and a hazard ratio of 0.16, a lot of us have decided that the bang is worth the buck and that we are thinking routinely about delivering this drug for resected EGFR mutant lung cancer, even though the drug is not yet approved in this setting.
Yeah, those are excellent points. And obviously the philosophic debate is, if people are going to live just as long, why torture everybody with the drug? Why not wait? until somebody really needs it by having a relapse. But then most people, given the choice, would rather not have the relapse and find out, because at that point we consider the disease incurable rather than curable, then it's just treatable. So I think that's a very important distinction. And another thing I liked is that you clarified the role of placebo, because there's this misperception out there that in research, we experiment on human beings and give placebo. So it's important to point out that placebo is only acceptable in research when doing nothing is a standard approach. So we don't just experiment on people with placebo. This has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.